Different countries employ different types of newborn screening. Some of them do only a TSH, some of them do only a T4, that is a thyroxine or thyroid hormone. Some of them do both. So what is the benefit of doing TSH sampling? What is the benefit of doing a T4 sampling? So primary TSH based is very much sensitive and more specific, but the problem is TSH can come normal in central hypothyroidism, so that can be mistaken, or it might also miss the delayed rise of TSH, which can happen in preterm babies. So in preterm babies, there can be a delayed rise of TSH, and that can miss congenital hypothyroidism in a primary TSH-based screening. So in a primary T4-based screening, that has the advantage of detecting both primary and central hypothyroidism, but it has a higher false positive result. So most of the places, and in India as well, we follow a TSH-based screening itself. So I know this flow chart looks a little bit complicated and confusing, but it's actually not very confusing. I'll just try to break it down for you in simple terms so that you can understand. So you do either a postnatal heel prick or a cord blood postnatal heel prick after 48 to 72 hours. When do you recall the child? So that is very important. So you need to know, when do you call the baby back? When do you put a high alert? So any TSH more than 20, okay, if it is less than 20, that is normal. Any TSH more than 20 in a newborn screening, you have to recall the baby back immediately. Then, if the TSH is more than 80, then you take a confirmatory venous sample immediately. You do not wait for the venous sample report. You start thyroxine treatment immediately. If the TSH is more than 40, then you send a venous sample, wait for the venous sample report, that is a TSH-free T4 report. Based on the reports, you decide whether to start treatment or not. If the TSH is between 20 to 40, then what you do, you recall the baby back again at 7 to 10 days of life, and you do a second screening. That is, you repeat the TSH again. When you repeat the TSH again, the repeat TSH can either be a venous sample or it can be a dried blood clot. Some people prefer to do of the venous sample directly. And then if the TSH is more than 20 at age less than 2 weeks or more than 10 at age more than 2 weeks, then we should send the confirmatory venous sample. So in a confirmatory venous sample, if the TSH is high and the T4, total T4 and the free T4 is low, you have to start the treatment. If the TSH, but however, if the TSH alone is high, but the T4 is normal, then what do? Then you repeat the TSH after 2 weeks. Even after 2 weeks, if the TSH is more than 10 and it's persistently more than 10 at the age of 3 weeks with a normal free T4 and total T4, then you start the treatment and you can reassess again at the age of 3 years. If the TSH is normal, but there is a low free T4. So any low free T4 less than 1.17, less than 1.1, low free T4 irrespective of the TSH, or free T4 less than 1.17 with TSH elevated, you have to start the treatment. You start the treatment, you do an imaging if possible, but do not delay the treatment because of the imaging studies. However, if there is a normal T4 and a normal TSH, that is TSH is less than 10 at the age of less than 2 weeks, less than 20 at the age of less than 2 weeks, or less than 10 at the age of more than 2 weeks, free T4 is more than 1.17, total T4 is more than 10, then that is normal. So you do not have to start treatment in those cases. So this is a complicated flow chart, but it is actually very simple if you actually look into the details and you understand it. So once we recall the baby back and we understand that the child has hypothyroidism based on the biochemical cutoff, then we need to go to something called as thyroid imaging. Why is thyroid imaging necessary and important? Because we need to know the etiology. So based on the etiology, we'll know, is it transient, is it permanent? That will help in counseling the family. And if some etiologies, they might require a higher dose, like suppose the thyroid gland is completely absent or aplastic, they will require a higher dose than a child with dyshomogenesis might require. And if we already find out at newborn period that the child's thyroid gland is not developed properly, there is ectopic or there is a dysplasia or an aplasia, then there is no point of stopping therapy at 3 years. So we know that it is permanent, the child will require lifelong therapy. So we just go on with life, continue the lifelong therapy. So Thyroid imaging, what all thyroid imagings can be done? So first we do the thyroid ultrasound that can be done at any time, any period. Thyroid nuclear imaging, this should usually be done within 7 days of starting thyroid treatment. Okay, because once the TSH comes back to normal, thyroid nuclear imaging cannot be done. Okay. And usually we do technetium 99, we can also do isotope radioiodine scan. And usually if there is no constraints with the financial constraints, we prefer to do both an ultrasound and the nuclear scan because each one has its own pros and cons. Better to do both of it. So as I mentioned, ultrasound can be done anytime. Thyroid nuclear scan should be done either before starting treatment or within 7 days of starting thyroxine replacement. And whatever being said, never delay the imaging, never delay the treatment for getting imaging done. As I mentioned, within the first 7 days of treatment, you can do the imaging. So you start off the medication and then you can worry about the imaging within the first 7 days. It should be okay. So based on the thyroid imaging, how do you find out the etiology? So you do a thyroid nuclear scan and you notice that there is no uptake in the thyroid region in the neck, but there is uptake at the base of the tongue. So this is suggestive of an ectopic gland or a lingual gland. And usually an ectopic gland will be circular in a thyroid nuclear scan and it will be very small. So it doesn't function properly. Thyroid scan shows does not have any uptake anywhere. It doesn't have any uptake in the neck or anywhere in the body. Then we do an ultrasound. Is the ultrasound visualized? In the ultrasound, is the gland visualized? Because as I mentioned, sometimes agenesis and maternal thyroid antibodies both will have absent uptake in thyroid scan, but ultrasound will show a thyroid gland. If there is a maternal thyroid antibodies, gland will not be visualized if it is an agenesis. If the thyroid gland is showing increased uptake of the radioisotope or technetium scan, and if the ultrasound is showing an enlarged thyroid, maybe a goiter is seen in the baby, then that goes in favor of dyshomogenesis. So to know what is exactly the etiology causing dyshomogenesis, as I mentioned, there are multiple enzymes which can result in dyshomogenesis. We can perform something known as perchlorate discharge test, or we can do directly a genetic test study for confirmation. So in perchlorate discharge test, we administer perchlorate. First, we administer iodine and then we administer perchlorate and we see how much of the iodine gets washed out. So if more than 90% of the iodine gets washed out, that will be suggestive of an organification defect. So usually that much of iodine should not get washed out. If it's getting organified and it gets it's retained within the body, that is normal. If it is getting excessively washed out, that is suggestive of an organification defect. If it is a normal uptake in a thyroid scan, the gland is also normal, then it might be still dyshomogenesis or it could be a transient hypothyroidism. So coming to the treatment of congenital hypothyroidism, so in a newborn baby, so the usual daily dose that we start, it can either be per kg per day, microgram per kg per day. We start at 10 to 15 microgram per kg per day, or we can also start it at microgram per meter square. That is, meter square is we calculate the body surface area and we start it usually at 100 microgram per meter square for newborn babies with congenital hypothyroidism. So thyroid tablets usually come at dosage of 12.5, 25, 37.5, 50. So based on that, we usually take the nearest dose round off and we give the nearest dose. So usually for a term baby, we can start off with 25 microgram and then based on the reports, either upgrade or downgrade. For a preterm baby, extreme preterm, say only 1.1, 1.2 kg, we can maybe consider starting at 12.5. So very severe cases, as I mentioned, any athyrosis, very high TSH, we can start at a higher dose. How do you administer the thyroid gland? So the thyroid medicine. So the problem with the thyroid medicine is it does not come in a syrup formulation. Many liquid formulations were tried previously, but it does not hold. It does not hold. That's the problem. It gets degraded. So it can only be administered in the way of a tablet. So what you have to do is you have to tell the parents, educate the parents how to give. You have to crush the tablet with a small amount of either breast milk or formula milk or water and completely mix it and take it either in a spoon, administer directly with a spoon or a syringe. So till 6 months of age, we have to do that. After 6 months, as I mentioned, breast milk or water. And never add the tablet to an entire glass or a feeding bottle of water, because then it gets diluted and the little bit of the tablet ends up sticking to the sides of the bottle, as a result of which a lot of the tablet is lost. So we always say 1 or 2 spoons of breast milk only. First, the crushed of the tablet should be crushed, then 1 to 2 spoons of the breast milk should be mixed, and then completely mixed, given to the baby. And again, you can add maybe remaining another spoon to make sure that the sides of the a mortar or pestle or whatever you're using to crush the sides also do not have remaining tablet. You can again, you mix a little bit of breast milk and then administer with a spoon directly. And they should be preferably given first thing in the morning, and never give any iron supplements, calcium, vitamin D. So usually we discharge a newborn baby with vitamin D supplements, and or maybe the baby is on a soya based formula, or the baby, newborn baby is on any iron supplements, calcium supplements. You never give it along with thyroxine. You can give it a little later in the day, preferably afternoon or evening. At least 4 hours of thyroxine. You should not give any of these. And very important, counsel. The family needs to understand what exactly is the problem. Is it permanent? Is it transient? What is the effect if they don't give the thyroid hormone properly? How frequently they should come for a follow-up, and how to take the thyroid medicine. So that is very important. And as I mentioned again, early and adequate treatment is the key to prevent neurological damage. So how often should a child come for follow-up? So as I mentioned, the first 3 years is very important for neuronal development, brain development. So the first 3 years of age, the child must come for follow-up very often. So usually what happens immediately after starting thyroid hormones, within the first 2 weeks, the thyroid hormones, that is the free T4 and total T4, will normalize, but the TSH will not. TSH normalizes only at 1 month of age. So the initial, after starting the medicines, you call them back after 2 weeks and you test the free T4, total T4 and see if it's normalized. That means that the dose is adequate. Then at 1 month, you call them back 1 month of age and you test the TSH. The TSH should have normalized at 1 month of starting medication. Then till 6 months of age, every 2 months, they need to do a free T4, total T4 and TSH and come for a visit with a pediatric endocrinologist. Between 6 months to 3 years, we can call them every 3 months. After 3 years, if it is a permanent etiology and till the growth and puberty is completed, we call them every 3 to 6 months. So what do we see on follow-up? One thing is we have to see how is the baby is growing, how is the baby development, is the development assessment proper, is the baby attained like holding, social smile, rolling over, has the baby attained the dentition, all that should be seen, head circumference should be checked, weight and height should be checked, and it has to be plotted on the growth chart. If it is an older child, then Tanner staging for puberty also should be done. Now coming to biochemical assessment. So how do we know that the thyroid hormone that we're giving is the dosage is correct? So the main idea is that the free T4 should be maintained in the upper level of the normal range that is given for each lab, and the TSH should be maintained in the lower half of the normal range. So this indicates that the compliance is good and that the thyroid dosage is also sufficient. So these are the age-wise cutoff for neonatal period. So there is a term neonates have a different cutoff and preterm neonates have a different cutoff. So this is easily available. You can follow the cutoffs. If you don't know, you can definitely look into it and then take a call whether the baby is actually having hypothyroidism or not. This is the age-wise cutoff for post-neonatal period. So 1 to 3 months, 3 to 12 months, 1 to 5 years, 5 to 8 years, 8 to 12 years, and 12 to 18 years. So how do we know? As I mentioned, there is a transient cause and there is a permanent cause. So how do you know whether it's a transient or a permanent cause? You recheck. When do you recheck? You recheck at 3 years of age. So that is provided that the thyroid scan and nuclear scan and ultrasound, that is evaluation, has not happened in the newborn period. If the evaluation has happened in the newborn period and we know evaluating at 3 years. If it does not happen, what do you do at 3 years? What you do is you usually stop the thyroxine for 4 weeks or 1 month. You stop the treatment for 1 month and you recheck the thyroid hormones and the TSH. If TSH is more than 10, that is an indirect marker that it is a permanent etiology. So you have to start the treatment. But what you can do then is you can do the imaging studies and then start the treatment, because the brain growth has already happened. So it's not going to make much of a difference if you don't give it for a few days. So then you do the imaging studies, then restart the treatment immediately. If the TSH is between 5 to 10 and a normal T4, then some endocrinologists would prefer to maybe continue the treatment for a while. Some endocrinologists might stop. It depends. We have to see based on how the baby is. So this will come under subclinical. If the TSH is less than 5, T4 is a normal range, it could have been a transient hypothyroidism. Then what we can do is we can stop the medication, but we need to counsel the parents that they need to be on continuous proper clinical follow-up, and at any sign, we have to restart the medicine immediately. So, as I mentioned, reevaluation is not required if it is a proven condition, or in the entire 3 years when the child has been on thyroxine, the TSH has always been high. That is also kind of like an indirect marker that it is a permanent etiology. And parents should also be very counseled that they must come for a follow-up immediately, that is within exactly 4 weeks or 1 month of stopping thyroxine. And it should never be like, you tell them to stop the thyroxine and come after 1 month, but they do not come. They end up showing up after 6 months. And, the child again has gone into severe hypothyroidism. So, as we all know, there is a syndrome of trisomy 21 or Down syndrome, and Down syndrome children have very high propensity of multiple thyroid issues. They can have central hypothyroidism, primary hypothyroidism, acquired hypothyroidism, and we've also seen subclinical hypothyroidism. We've also seen incidence of congenital hypothyroidism is higher in Down syndrome babies. So a proper evaluation and checklist is very essential. Yearly TSH screening is required. A combination of high TSH and normal T4 is noted. As a result, if it's a Down syndrome baby, we have to always do a second screening at 2 to 4 weeks. And for treatment, the guidelines is the same. Normal children, Down syndrome baby children, the dosage, follow-up, everything is the same. However, one thing is subclinical hypothyroidism in normal children, that is a TSH of 6 to 10, we might wait, we might not start. But if it is a Down syndrome baby, better to start the treatment. However, there is no clear-cut guidelines on this, but this is the basic idea.